One of the really important ways that the Yale School of Public Health impacts public health beyond Yale is through the work of our students and alumni, as Paul has already shown. Today, we're going to highlight the work and ideas of 5 of our students to give you a sense of the breadth and future impact of our students. I'm going to take the opportunity to highlight a little of the background that feeds the work that each of them will be presenting. In terms of format, I'm going to go ahead and introduce all 5 of the presenters in order, and then they will go ahead and speak one after the other. We encourage you to seek the presenters out following their talks and talk with them at the end of the session, as we're not going to be taking questions during their talks. Our first speaker, Hannah Kaneck, worked in public health regulation before coming to Yale. In the environmental health sciences track, she's had the opportunity to study exposure and risk assessment. The combination of coursework and her previous work in public health regulation has led to her decision to pursue the regulatory affairs track at YSPH with an eye to a future career working in public health and substance abuse. This background is integrated in her presentation, Up in Smoke, How Marijuana Legalization Affects Us All. Our second speaker, Ruchit Nagar, took a course on appropriate technology for the developing world at the Center for Engineering, Innovation, and Design as a junior in Yale College. Through the innovation he worked on in that class, Khushi Baby, and the opportunity to participate fully in the innovation process, Ruchit has found a passion for social entrepreneurship. In 2014, the Khushi Baby team won the Thorn Prize for Social Innovation in Health. This past week, Khushi Baby was named one of 2 winners of the UNICEF Wearables for Good Challenge out of 250 applicants from 46 countries. Many of you had the opportunity to hear Ruchit last year as part of the presentation on entrepreneurship at Yale. He'll be providing an update on the progress of Khushi Baby in his talk entitled Khushi Baby, a wearable platform to bridge the world's immunization gap. Yuna Lee is our third speaker. She worked at the New York City Health Department as the Special Projects Coordinator for the Chief Operations Officer prior to coming to YSPH for her PhD. This gave her a lot of exposure to how people work in organizations. Her PhD coursework in health services research, quantitative methods, and classes at the School of Management on organizational behavior allowed her to bring new insights to her reflections on those experiences in healthcare administration. The most pivotal course she took was the Creativity and Innovation course at SOM, where she learned how to encourage creativity within organizational settings. She will share that passion with us in her presentation, Building Creative Healthcare Organizations for Quality Improvement. Alex Rich brings years of experience as a military pilot with committed attention to safety and efficiency to his new career in public health. He's developing his technical skills with courses such as database architecture, managing software development, and healthcare strategy. He's also volunteering with the clinical redesign team at Yale New Haven Hospital and helping to plan the Yale Center for Biomedical Interventional Technology Yale New Haven Hospital Healthcare Hackathon in January. His commitment to straightforward, workable solutions will be evident in his presentation on simplicity in cargo ships and healthcare. Our final speaker, Laura Skrip, that you saw briefly in that video, has always enjoyed math, and she wouldn't have considered majoring in anything else during college. However, when she first started traveling with a medical anthropologist and gaining international field experience, she wasn't sure her new passion could be integrated with her quantitative background. At YSPH, Laura has learned to do just that, and she is now studying mathematical modeling of neglected tropical diseases. She will share her experience integrating these passions in her talk on Ebola, math, risk, and global health crises. Hannah?
Thank you. If we could take a moment to envision a high-powered attorney, a primary care physician, and an elementary school teacher going home after a long day of work, and instead of pouring a glass of wine to relax, rolling a joint to smoke. This is the reality in states like Oregon, Washington, Alaska, DC, and Colorado, where not only medical marijuana has been legalized, but retail has as well. And anyone over the age of 21 can walk into a dispensary and buy marijuana, just like you and I can walk into a liquor store and buy alcohol, or into a convenience store and buy a pack of cigarettes. In 2012, I graduated from Trinity College, and I moved out to Colorado, where my parents live. I got a job working as an FDA tobacco compliance specialist. I can't tell you a whole lot about that job, but I can tell you that I was working really hard to keep nicotine out of the hands of impressionable teenagers. This was kind of a dream job for me. My entire family smokes. I grew up in a house of secondhand smoke. And for those of you who can relate to this experience, you could probably relate to my personal vendetta against big tobacco. That was 2012, the same year that Amendment 64 was passed, with 54.8% of voter approval in Colorado. Amendment 64 allows for the possession, growth, and use of marijuana by private citizens. It also sets up regulation and taxation of dispensaries. But this wasn't Colorado's first walk on the wild side. Medical marijuana had been legal since 2000. Medical dispensaries have been open since 2009. In fact, it was commonly written that there were more dispensaries on a Denver city block than there were McDonald's and Starbucks combined. This is Colfax Avenue, Main Street, Denver, if you will. We have a donut shop, a tattoo parlor, and a dispensary. Seems kind of normal, right? On January 1st, 2014, retail dispensaries were able to open, and the state made millions and millions of dollars in tax revenue, all regulated by the Department of Revenue. But they're not the only bureau in charge of regulating marijuana policies. This last summer, I got to work as the marijuana program intern at the Colorado Department of Public Health and Environment, which is tasked with many jobs, but most importantly, they review the academic literature and provide evidence-based recommendations to the state legislature with regards to adverse health outcomes. And if there's one thing I learned as an intern, there's a very clear paucity of high-quality, population-level data with regards to adverse health outcomes and marijuana use. You see, the state really wanted to do this long-term comparison of pre-legalization population users and post-legalization population users. But they couldn't because there wasn't baseline data. They didn't know what that population looked like pre-legalization. Who was using, how were they using, what were they using? We didn't know. What we do know is that when you use marijuana, especially at high doses, often due to accidental overuse, we see things like cyclic vomiting syndrome, anxiety, depression, psychosis. More fatally, we see things like automobile accidents that not just affect the users, but the public as well, especially when combined with alcohol use. This is a huge problem. We've seen an increase in ER visits, hospitalizations, poison control center calls, all related to marijuana use. And this is where dose becomes an important part of the equation. Dose of what? Dose of THC, tetrahydrocannabinol, which is the primary hallucinatory agent in cannabis. This is a chart that shows the increase in percent THC in cannabis over time. This was released by the federal government. However, it doesn't illustrate what's going on in states that have legalized, because botanists in states like Colorado are producing plants that have more along the lines of 23 to 27% THC. So if you take this tallest bar here, duplicate it, and stack it on itself, that's the reality in states that have legalized. What does this tell us? This tells us this is not the weed your parents were smoking in the 60s and 70s. This is a completely new drug, a drug that we don't know a whole lot about. And whenever you introduce a new drug to a population, there's a learning curve of use. And this was indeed the case with marijuana. You see, we did such a great job in the 90s teaching people that cigarettes equal bad, smoking equals bad. That naive users of marijuana, people who have never used before, or people who used when they were young and want to experiment now, they want to avoid smoking altogether, because that's what we taught them. Okay, good job for us. But now they're turning to edibles. Edibles are cannabis-infused foods. And the average, they normally come in like pot brownies or cookies, and the average Colorado cookie edible has 100 milligrams of THC in it. The recommended safe dosage is 10 milligrams. It's almost lunchtime. I know everyone's getting hungry. So I'm going to show you a picture of a cookie. Could you eat 1/10 of this cookie? Probably not right now, right? What would happen if a child got a hold of this cookie? It takes a half an hour for an edible to kick in. You eat one of these cookies, you wait 10 minutes, nothing happens, so you eat another cookie. In 20 minutes, you're feeling the effects of 20 times the recommended dosage of THC. And you might be feeling some effects, maybe different ones than what I spoke of earlier. Maybe you have heart palpitations, paranoia, maybe you've blacked out, who knows? Don't like cookies? That's okay. What do you like? Swedish fish? You like Rice Krispie treats, soda pop? You name it, they make an edible out of it. And the thing about edibles is that they're marketed, produced, and sold in a very familiar fashion in displays behind the cashier, lots of colors, lots of flavors, discreet packaging. To me, these edibles look like packs of cigarettes, e-cigarettes, those tiny bottles of alcohol you see at the liquor store. If there's one thing I learned from regulating tobacco, it's that the most effective laws are the ones that target big tobacco's ability to appeal to young audiences. They have made an art out of creating new generations of smokers, new generations of users. They call them replacement smokers. It would be naive of us to think that the marijuana industry won't or already hasn't succumbed to the same interests that tobacco has had for almost a century. This is a great opportunity for public health. We can take what we learn from tobacco, apply it to marijuana legalization. This is our chance to not let history repeat itself. I'll leave you with this. We're seeing higher dose products that are more accessible at lower prices. We're seeing effective marketing to vulnerable populations and normalization of use. Are we ready for legalization? Thank you.
All right, how's everyone doing? All right, great. I know it's close to lunchtime, so hang in there. My name is Ruchit. I'm here to talk to you guys about Khushi baby. Khushi is a Hindi word, it means happy, and our goal at Khushi baby is to have happy and healthy babies. What we're trying to do is we're trying to make a wearable platform, and I'll explain what that is, to solve the world's immunization gap. So speaking of the immunization gap, let's talk about this number. 500,000. 500,000 kids under the age of 5 die every year in India from vaccine-preventable disease. Just take a moment to let that soak in. 500,000 kids die from preventable disease. And this is just symptomatic of something that happens around the world. Close to 1.5 million children die, and most of these kids are dying in developing countries for things that we have solutions for. So what is the government of India doing? They have a campaign called Mission Indradhanush, and they're doing this media campaign telling families to be wise, immunize, make sure your child gets all 10 vaccines. But it's not that simple as this cartoon tries to portray, because not only do you have to get those first 10 vaccines in that first year of life, you have to get them according to a very specific timetable. So why are people going under-immunized or unimmunized? UNICEF did a big study in 2009, and they interviewed over 10,000 mothers. And what they found is that mothers did not feel the need or did not know about vaccines as the major reasons why there was under-immunization. So people can get under-immunized because of demand-side factors or supply-side factors. In this case, their hypothesis is that people just don't know. There's not a high level of awareness in certain pockets of the community. So what do those pockets of the community actually look like? Well, in order to get a better sense, you have to go to the field. You have to go to the far-flung last-mile villages, which have the lowest rates of immunization. In fact, we don't actually know what the rates of immunization are because there isn't good data on it. So what does that look like? How does a vaccine get to the last mile? This was the problem that we were sort of tasked with a year and a half ago at the Center for Engineering, Innovation, and Design. So I'll tell you the story that I've come to get a sense of over the past 2 summers. It starts with a traditional birth attendant who lives in the village, has to keep track of 10 to 15 mothers who are either pregnant or with infants. She has to go walking 10 kilometers a day, reminding them when to come in for immunizations. Meanwhile, you have a health worker who gets on his bike. He drives through tough terrain for over 2 hours with a vaccine box strapped to his side. The mother has to leave her job, usually on the farm, with child in hand, and walk for about an hour through monsoons or through 100-degree-plus weather to arrive at a campsite, which really is like it might be a school building, it might just be a building, and you're really on the patio of that building in this organized chaos. Finally, when you get your 5 minutes of fame with the health worker, you have to present your health information, and this is something that we're all familiar with. So how does that work? You have a paper card that you're supposed to hold on to for almost 2 years, throughout the antenatal care period and through the period of routine immunizations. If I were to ask you to hold on to a piece of paper for 2 years, it's not an easy thing to do. People try, they put it in plastic, but ultimately, the paper cards are often not even filled out. So that means the health worker has to guess, was your child born before or after the harvest in order to determine which vaccine to give today. And that's not good enough. Even if we are able to make that immunization possible, there's one step that often goes unfinished, and that's the step of documenting the whole event in the first place. Everything is written down on paper, which means it's hard for health officials to know what's going on. It's hard to search people's names. The information is lost. We want to get that information because that information is important. We need to know which kids are going under immunized. We have to know which specific kids are going under immunized, not just generally in the state or in the country. So what have we tried to do? We want to make sure that everyone owns a digital copy of their health in the form of a necklace. So we want to replace this card in a sense, or supplement it with a wearable, something that can stay with you, something that's digital, that acts as an easy touch point to the healthcare provider, something that stores your data in a completely decentralized and offline manner. So you don't have to be connected to the internet in order to look up someone's health information. You don't have to have a laptop. You simply have to scan the necklace with our app in order to figure out which vaccines the kid has already received and which vaccines I need to give today. One other thing I'd like to talk about is that the necklace has a black thread. And this is important because we're not simply trying to dump technology in the hands of these communities. The black thread has a very important symbolic meaning in these communities to protect the child from evil eye or evil spirits. So we also have to think about who's going to adopt that technology, who's going to use that technology, and how can we promote health-seeking behaviors through the actual form of what we're trying to make. The information eventually will get pushed up to health officials by taking advantage of 2G signal, which is actually of a very high penetration in India. So healthcare workers have real-time analytics, location-specific analytics, patient-specific analytics at their fingertips. They can even do things like call mothers in these communities, reminding them when to come in, because we can collect their phone numbers and sort of control it in an automated way. And that really gets me to sort of the last thing I'd like to talk about, which is we're not just trying to collect data, and that's a huge issue that we're trying to address. We're also trying to address this earlier issue of generating demand, generating awareness. There are many mHealth projects, electronic health projects that are trying to collect data. We need to go one step further in order to actually improve immunization. So how are we going to do that? Well, first of all, we think the necklace can act as a social signal, like a Livestrong band, for people to start talking about immunizations. They can ask, oh, where did you get that? I got it at the immunization camp. Maybe I should take my child there. We have voice call reminders in the local dialect. There are many dialects in India, and it's very important to be able to reach and remind mothers so that way they follow the appropriate health-seeking behavior. We want to give healthcare workers a list of patients that they should expect to see. They travel so far out there, and then they don't know who should come or who shouldn't come. They just immunize whoever comes. That's not going to be good enough. We need to have a better idea of what the true demand is. We need to know how many vaccines we gave out, but also how many times we couldn't give out a vaccine because the vial would have been spoiled or because the mother didn't want a second injection. We need to think about mothers and how they're connected in a social network approach. Who's going to be influential in society? Who can we recruit or use as a recruitment champion to bring more mothers in? And how can we target mothers early on, during the antenatal care period, so that way their health-seeking behavior can be improved throughout the first year after birth? These are all things that we're thinking about that are I'm looking at in my own thesis research, and that are going to be integral to moving this project forward, not just for efficiency, but also for program efficacy. I want to take a moment to thank you all and to also talk about the progress that we've had in the last year and a half. We started at the Yale Center for Engineering, Innovation, and Design, and we are now rolled out in over 100 villages, tracking over 1,000 children with our system. We have raised a lot of money, and that is really, our success is your success because you've supported us. We've had the umbrella of support from the Yale community, from the CEID to the School of Public Health, YEI. If you want to continue to get engaged or involved, please go to KhushiBaby.org, KHUSHI. Feel free to contact me after. I can't answer any questions right now, but I will be available after to discuss further. And we look forward to your continued feedback and support as we go from a startup to a scale up and really try to take this innovation for public health to a broader scale. Thank you. Sorry.
Click on your name.
Okay.
If I don't do it for you, which I will.
All right. See?
You ready to go?
Why press?
Control.
Okay, so where do I put the microphone?
That's got to be in your pocket or reach me to hold it.
Okay.
Good morning, everyone.
Oh, sorry.
I grew up watching my family run a very special line of nursing homes in Australia. I saw how the smallest actions on the part of the staff could lead to huge improvements in patients' experience of care. Take the example of Tony. Tony was a kitchen server who would carry plates from the kitchen. Tony towered over patients in wheelchairs, and he empathized that it must feel dehumanizing to be talked down to all day. So one day, Tony knelt down beside the patients and met them at their eye level as he spoke to them and placed down their plates. It was a moment of connection, compassion, and respect that made all the difference. Today, all 500 staff meet the patients at their eye level as they speak to them. I've discovered that improving the patient experience is like this. It's the accumulation of quiet but meaningful operational changes that matter to patients. In the United States and throughout the world, healthcare is undergoing a transformation. It's a reaction to the recognition that our current systems are just unsustainable. In 2015, the United States will spend $1 trillion on hospital care, but only 71% of patients would definitely recommend their hospital based on their experience. The patient experience is rapidly becoming a top quality issue. Humane and empathetic care is the right thing to do. It improves patient safety and clinical effectiveness and is now being tied to Medicare reimbursement. So for the first time, not only if the care worked, but also if the care was respectful and responsive to your needs and values matters. Now the two sound like they're related, but they're not the same thing. Research has shown that great clinical care outcomes don't always equal a great care experience. So in healthcare today, most of the innovations that we see come from Silicon Valley or from labs, which are great for finding cures and combating disease, but it's just not the whole story. Parts of the healthcare journey, like building trust, relationships, and continuity of care, they just can't be solved with an app. What we need to improve the patient experience may already be lying within our healthcare organizations. Profound ideas for quality improvement arise every day from healthcare's front lines. Just look at Tony. We just have to learn how to catch them. I study the science of creativity in healthcare organizations for my doctoral dissertation at Yale. I would like healthcare to start thinking about creativity, which is a process of generating novel and useful ideas. In other industries, creativity is used as a tool, for quality improvement, and also a resource to help organizations adapt and learn. Healthcare organizations can learn to do this too. So I was recently surprised to know that the stars of the recent Pixar movie, Inside Out, almost didn't make it to the big screen. It turns out that creativity doesn't just happen. It's not some abstract, freewheeling light bulb moment like we see in the movies. Creativity results from organizations being adaptive, collaborative, but most of all, deliberate in their choices to nurture and savor good ideas. Now, Pixar has dominated animation for 20 years and is always setting new standards for originality. But the premise behind Inside Out, that a whole movie could focus on the emotions of an 11-year-old girl, was wild even for their standards. So there's a special place in Pixar where you can pitch new ideas without fear of looking stupid or putting your ego on the line. They call it the Brain Trust. The Brain Trust is a rotating team of Pixar staff from all ranks of movie making who listen to good ideas, provide honest feedback, and then work for months together to make the good ideas happen. Thanks to the Brain Trust, the writer with the idea felt safe enough to speak up, and thanks to Pixar, the world now enjoys the fruits of this wonderful idea. Pixar has to deliberately organize for creativity, and they're in a creative industry. So healthcare may face some special challenges eliciting creativity from its frontline staff. Healthcare is ordered. We have checklists and we have rules to reduce risk. Healthcare is hierarchical. The right to speak up often comes with experience and status. Healthcare is complex and it's high stakes, and for the professionals inside, it can sometimes feel that they have very little control over their work and just little time to be creative. So how do we foster creativity in healthcare? So I study a real-life creative healthcare organization in my work. They're a primary care system based right here in Connecticut, and they do a lot of work to address these challenges and honor the voices of its frontline staff. I've been visiting this organization for 3 years, and lately I've read hundreds of pages of meeting minutes, because it turns out that this organization has a brain trust of its own called the Clinical Microsystem, where frontline care staff get together weekly and brainstorm and work out ideas to improve the patient experience. So I've been extracting creative ideas out of these minutes, and I'll have experts rate them for level of creativity. I'll then be bringing together other sources of data to start painting the picture of what makes this organization creative. We surveyed frontline staff, so physicians, nurses, medical assistants, and behavioral health providers, about their experience of work. Do you feel like part of a team? Do you feel like you can speak up? We then virtually followed them around for a week, and by that, I mean that they wore these super cool electronic social sensors that click every time they speak to another care member. And these badges give us a sense of their social networks and how chatty and social they are at work. And finally, we ask patients about their experience of care. So bringing all of this data to bear allows us to answer questions like, how creative are these ideas? What does the journey look like for a creative idea over time? Are good ideas getting lost and forgotten, or are they evolving and becoming implemented as innovations? Who is creative at work? Is it the new recruit with the fresh eyes, or is it the old guard who's been around and seen the breakdowns? And how connected are they? Are they having diverse conversations and being exposed to diverse perspectives, or are they hanging out with their own kind, their own role? Who is speaking up at work? Is it the medical assistant or the physician? And who's dominating and interrupting conversations? So through this work, I hope to uncover what makes healthcare organizations and how that relates to outcomes that we really care about, such as the patient experience. In conclusion, creative ideas have the potential to improve the organization and the experience of care in settings as diverse as hospitals, nursing homes, to in the field. Healthcare organizations can organize for creativity. And by doing so, we're bridging the gap to a better patient experience. Let's reimagine healthcare as a creative industry. Great ideas are just waiting for us to find them. Thank you.
Okay, we will get you to lunch here shortly. I promise I'll be as quick as I can. Today I want to tell you a story about the expansion of one of the most powerful and potentially dangerous industries in the history of mankind, and the advancement of the most powerful tool ever developed by our species. And I want us to view this together through the lens of one of my favorite concepts, that of simplicity. I want you to think about big, complicated systems with misaligned incentives and the production of simple solutions that are person-centered and the impact of that on society as a whole. Our story begins in the middle of the 19th century in England in small shipping communities, and it starts with a man named Samuel Plimsoll. Samuel had a little bit of a difficult life. His father died at an early age, and Sam went to work to support his family. Eventually, he built up a coal speculation business and lost it, and was out on the street, and was too proud to ask for assistance from his friends and family. So what he found was that he really identified with the generosity and kindness of the working poor in England. And he built really strong bonds with those people that he retained even after he recovered and got himself into Parliament and became pretty important in society. Samuel found in his time with them that for the first time ever, there were a lot of young men disappearing from these shipping communities. They'd go out on cargo ships and never come home. And in an era before Google and Facebook, it was very difficult to find that pattern and draw it down to its cause. What he found was that for the first time in the history of shipping, it was possible to over-insure a cargo ship, to insure it for more money than it was worth. And this was causing some unethical ship owners to send their ships out to sea overloaded and overinsured, so that if the ship sank in the middle of the ocean, they made good money because they got the insurance money. And if the ship made it to its destination, they made good money because it got there with more cargo than it rightfully should have. So in digging into this problem, Sam was very, very tenacious because it was a very complicated problem. He went well outside his discipline to try to find the solution. He went first to the ship owners and said, hey, can you police your own? And they said no, because we don't want to call out any of our people. This is very socially unacceptable to us. So he went to the insurers and said, hey, could you develop some regulation because it's in your incentive to not insure ships that are going to sink? And they said no, because we've distributed the cost so much that it costs me less to pay for a ship that sank than it does to refuse to pay and lose my reputation as an insurer. Same story with the captains, because for a captain to refuse an overloaded ship made him a coward who was unemployable. So what Sam came down to was the person to make the decision was the individual sailor getting on board the ship. But the problem was that the system was too complex. That sailor had no way to see if the boat was safe or not. So Sam made some friends who were naval architects. And what he was able to do was take that big, complicated system with misaligned incentives and lots of different parties, none of whom were there to protect the individual, and distill thousands of hours of naval architecture into a single, simple symbol that you could put on the side of a ship. And anyone, regardless of their education level, could see if that symbol was below the waterline, that ship is unsafe, do not get on it. So after discovering this, Sam got into Parliament and began a 10-year-long battle to get this mandated. And he found that he was rebuffed and rebuffed and rebuffed repeatedly because everyone in the system that was so misaligned had friends in Parliament. And Sam almost got himself kicked out of Parliament in this fight. Eventually, he wrote a book that became incredibly popular, went to the people, got it forced through. And today, if you go to any major commercial shipping port on the planet, you will see a variation of the Plimsoll line. Sam Plimsoll, by taking an unbelievably complicated problem and distilling it into a simple human-centered solution, has saved tens of thousands of lives long past the duration of his own life. It's a big deal. I followed my own symbol into my first career. This is my grandfather. This is my grandfather. He was an aerial gunnery instructor in World War II, and he was my hero. And so I followed his path into being a military pilot. I flew KC-135s, and then I transitioned to flying an airplane about a tenth that size, a little single-engine U-28 for Air Force Special Operations Command. And it was the time of my life. I loved it. Did it for about 10 years, deployed 10 times. And on my 10th deployment, two things happened that changed the course of my life. First of all, after 10 deployments and having gone down for medical reasons once or twice, I found that in my last deployment I was unable to fly medically about 4 different times. We couldn't figure out what the problem was, and eventually it disqualified me from flying status. This was my first real brush with healthcare. I had seen primary care doctors annually before that, but I'd always been pretty healthy. This drove me to a specialist, and what I found was an unbelievably complicated system with incentives that didn't always align and communications that didn't always get the right information to the decision maker. I found that my specialist, who I got to see after 4 months of waiting, couldn't always transmit the results of my test to my primary care doctor. And when it got there, I had to carry paper to back it up. And it was very difficult for us all to make the right decision. So I see a tremendous opportunity to do the same kind of simplification thing inside healthcare. The other thing that happened was my grandfather passed away about a week before my last return from Afghanistan. And what we found subsequently was that it was driven by a problem with taking his medication on time. Think about that. In this country, we've spent hundreds of millions of dollars developing the right drugs and hundreds of thousands of dollars training the right doctors. And we did all that right. We got to the 2-yard line with this thing, and we got the medication onto his counter. And the thing that kept us out of the goal line was the fact that he had a hard time knowing what time of day it was when to take his pills. And we didn't find out about that problem until he was in the emergency room. I believe we can do better than that. And so, having thought about that a lot and having spent, a portion of my life doing a very different kind of mission. I was lucky enough to be able to fly a mercury-poisoned baby across the Pacific to safety at 9/10 the speed of sound. And after that, I got to fly over the top of SEALs and Rangers as they assaulted terrorist compounds, making sure that they were safe. But the most important mission of my life so far is this: finding a way to take this incredibly complicated system and simplify it. Because every year, 125,000 Americans die from prescription adherence problems. This is a problem that will touch everyone in this room if it has not already. And really all it needs is to center the system around the patient, to be able to get the medication to the patient and to be able to see every day that lights and buzzers attract the patient's attention, get them to take the pill on time, and if they don't, to close the loop via cellular communication to either a family member or a care provider. Simple as that, so that you find out the day that they don't take the pill instead of the day when they arrive in the ER and it's too late. So that's what I've been working on. And this is one of those days where I very nearly committed to a PhD program at Texas A&M. So I love Texas, but this is one of those days where I'm a little bit happy to not be in Texas. This is not a clock, but it has a clock in it. This is what I've developed. It's a little bit of an ugly prototype, but it does the thing. And so this is going to be a long battle. It might be a 10-year battle. There are a lot of people trying to do this. And I hope that one of them gets there before me. But if they do not, this is what I see as the solution. Something simple that takes an unbelievably complicated problem with lots of misaligned incentives and centers it around the patient so that we can get it right the first time, every time. Thank you.
Aren't you scared? Friends were asking. Well, I had crunched the numbers and knew that as of September 4th, there were 1,871 cases in Liberia. So the crude probability of any individual catching the disease in the country was 1/25%. No, I was not worried about getting Ebola. I got to Monrovia with a classmate in mid-September of last year. Within about 8 hours of checking into the hotel, we were due to meet with the Deputy Minister of Health. felt like a really big deal meeting him. I remember going in for the handshake. He graciously smiled, but backed slowly away. A series of awkward bows and fake elbow bumps ensued. There's a no-touch policy in Liberia. Minister Ninzwa escorted us to a data management meeting where CDC staff was explaining the exponential trajectory of the epidemic curve. Every day, there were more and more cases, and the close contacts of these cases required follow-up. We then sat down with the head of the Liberian data management team. He said they were having trouble keeping up with the massive amounts of contact tracing data. Would we be able to help develop an app for that? We went to several other meetings, and the common theme emerged. We were constantly being asked, have you heard about the contact tracing issues? So what is contact tracing? It is a way to intervene and interrupt before new chains of transmission begin. So a suspected case develops symptoms. Since Ebola virus is transmitted through bodily fluids, people who are in closest contact with the case are at greatest risk of developing the disease. So in theory, these close contacts could be followed or traced for a 21-day period so that if any of them started to develop symptoms, they could be quickly isolated before transmitting to their own networks of contacts. In reality, though, contact tracers were documenting all of this information on forms, and paper was simply piling and piling. So you could imagine how an app would be pretty appealing. And oh my goodness, everybody, CDC, WHO, eHealth, they all wanted their name on this hypothetical app. But it was a pretty complicated undertaking. My classmate and I are not necessarily traditional graduate students. We had years of international fieldwork combined, and we were not in Liberia as an academic exercise. We were there to do something, and we really wanted to contribute to the data management problems with contact tracing. So we first set out to solve some of the ministry's server issues. We prepared a PowerPoint slide deck. And well, first of all, for this server, I mean, once this contact tracing app was developed, the data would need to go to a secure and stable environment. So we prepared a PowerPoint slide deck, and we went to Minister Ninzwa's office, and we sat and waited and waited and waited some more because we wanted to introduce him to the cloud. Now, Minister Ninzwa soon thereafter returned the favor. He introduced us to Dr. Masoka Fola, who was leading the field efforts for the Liberian team in Montserrado County. And Dr. Fola told us about his community-based initiative that we now call CBI. So Montserrado County is divided into 22 zones. There are 212 communities and 190,000 households. And these households made up blocks of about 25 homes each. So since there are no formal addresses in Liberia, Dr. Fola was trying to map Montserrado County out zone by zone. He was then recruiting and training community members to go door to door and collect simple but essential information. He wanted our help with data management. Now, we kind of knew right then and there, Dr. Fola, you most definitely need an app. So we went and we observed and talked to the boots on the ground, and that's what Dr. Fola was calling the community workers he was hiring. And we started this app. While I worked on fine-tuning the logic and the usability of the front end, my classmate was developing the entire back end. And so with the extraordinary help of friends and family members back home, in about 2 weeks' time, we had an app, we had a couple dozen phones, and I'll admit, we had a paper form. But we had a plan for dealing with it. Active case finders would go door to door, and they would collect information on these forms about the number of sick individuals, the number of deaths, how many visitors there were. They would take these forms at the end of each day to a supervisor who would aggregate it and have one line of data per block. This single sheet of paper would then go to the monitors. And these were the people with the phones for the app. So we piloted this in the Caldwell district, and we asked people what they liked, what they didn't like about this form, and we taught the monitors, many of whom had never used a touch screen, how to use the app. It seriously took about 2 tries. They were very determined. Now, about this time, there was another epidemic gaining speed. First transmission events were taking place outside of West Africa in Dallas, Texas. And this other epidemic of fear and hysteria was growing rapidly, fueled by the media and misinformation. When we returned to the US, the crude probability of any person catching Ebola in Liberia was 0.1%. But in a few days, it became clear that the probability of quarantine was certain. The probability I'd be confined in my apartment the next day, 100%. But you know what? Let's go back to Liberia and actually fast forward a few weeks. Ebola was everywhere, but in a completely different way. The Ebola is Real song was playing on the radio. The Stop Ebola mural that a local Monrovian man had painted was making headlines, and local community members were enforcing no visitor policies. They wanted to kick Ebola out of their communities. Now, at this time, for the first time since the epidemic started, there were empty beds in treatment units, and people were taking a cautious sigh of relief. Dr. Fla was even able to leave and come visit internationally to share the lessons he had learned in the field. He visited us here at Yale to give us an update on CBI. That Caldwell pilot had gone so well that there were now over 5,500 active case finders going door to door to collect information. This information was being aggregated, and the data was being sent real time via app to decision makers at the Ministry of Health, who could then deploy ambulances, contact tracing teams, and burial teams to hotspots. This approach is totally generalizable. Active surveillance could be used to find cases of any disease, from malaria to flu. Holy cow. Now this is why we do public health. So the epidemic in Liberia ended months ago, but CBI has been tailored to now follow up with Ebola orphans and track their education needs. The app has been updated to do this, and actually another app is underway to follow the psychosocial needs of Ebola survivors. And speaking of survivors, we're actually teaming up with SmartStainable to recruit some female Ebola survivors. They're going to learn basic computing skills and actually how to program and code so that they can make their own apps. This active surveillance system will be completely sustainable at that point. So the math is pretty simple. Some accessible technology, such as what we developed with the help of SmartStainable, strong coordination and active community engagement, as Dr. Falah was able to accomplish, is kind of critical for a healthier, more empowered population. So simply put, even in an unprecedented epidemic, it is possible and essential for your health to effectively become our health.